Hi guys, here is Hani Hadi Muhammad. I will be your guide here in this course, the course of endocrine pharmacology. So I wish you a productive learning experience in this course. Today we will talk about the adrenocorticosteroids and adrenocortical antagonists. So what we mean by these two terms, the adrenocortical antagonist, mean these medicines, these agents responsible to counteract the actions of the adrenocorticosteroids. So the question is, what are the adrenocorticosteroids? The adrenocorticosteroids are group of hormones that produce naturally inside our body. For example, we have the glucocorticoids, mineralocorticoid, and adrenal androgens. So each one, or the adrenal, let's talk generally about the adrenocorticosteroids. They are very important for the normal physiology of the body. For example, in case of glucocorticoid, it is very important to regulate the metabolism in the body. It is very important for normal immunological function, and also it is very important for inflammatory process and very important for tolerating the stress. Mineralocorticoid, it is the aldosterone, for example. It is important for water salt reabsorption, retention. This is important when the body exposed to a low in the blood pressure, exposing to decrease in the blood pressure. Aldosterone, it is activated and lead to increase the blood pressure. Adrenal androgens, or the sex hormone, like for example the DHEA. And the DHEA, I'm sure that you hear about it and you see it on the supplement products in the pharmacies. So DHEA, it stands for dehydroepiandrosterone. So if you see this, if you think this word or this term is long, you can divide it into three parts or two parts in order to make it easy to memorize it. For example, dehydroepiandrosterone, you can divide it into dehydro and epiandrosterone. We have another examples or another adrenal androgens like androstenediol and androstenedione. The important thing you must know that these hormones, these adrenal androgen, these sex hormones, they are weak hormones. Okay, they are only responsible for some simple change during the puberty. For example, growing the hair in some private area, like for example pubic and axillary hair. And it is very important, the normal level of adrenal androgen, the normal level of corticosteroid, it is very important, especially for postmenopausal women. If you ask me why, I will tell you that the adrenal androgen, it is a precursor for synthesis of the potent form of estrogen. We all know that after menopause or postmenopause age, the level of estrogen change, the type of estrogen change. For example, the estrogen, the potent one, is called estradiol. The weak one called estrone. Okay, before the menopause, the estradiol, it is the predominant form, while after menopause or postmenopause, the estrone become the predominant form. But if the adrenal androgen, it is normal, so adrenal androgen give rise for synthesis of the estradiol. And you all know that in the postmenopause, and when the estradiol decreased and estrone increased, such a woman will be exposed to number of complications, like for example hot flushes, like for example osteoporosis, like for example increase the risk of cardiovascular disease. Okay, so it is very important to maintain the corticosteroid adrenocorticosteroids in normal level in order to maintain the estrogen level or the potent estrogen level normal. The these hormones, the adrenocorticosteroid hormones, are biosynthesized by adrenal gland. Okay, this adrenal gland located on the kidney, as you see here, and there are divided into two parts. The adrenal gland divided into the cortex and also divided into the medulla. Okay, these hormones, these adrenocorticosteroids, from the name adrenocortico, mean it is they are biosynthesized in the cortical part of adrenal gland. Okay, the adrenal cortex by itself, it will be divided into three more layers: the zona glomerulosa, the zona fasciculata, and also the zona reticularis. Zona glomerulosa, it is responsible for biosynthesis of mineralocorticoids like aldosterone. Zona reticularis, responsible for androgen hormones synthesis like testosterone and estrogen. The middle layer, which is called the zona fasciculata, which is responsible for cortisol biosynthesis. Okay, so the zona glomerulosa, as you see here, it is the outermost layer, while the innermost layer, it is zona reticularis. Okay, this is the pathway of adrenocorticosteroid biosynthesis, and it is very important to know how the biosynthesis take place. And this is make you to understand how the medicines, how the adrenocorticosteroid inhibiting agent or antagonistic agent working, and also you will understand the pathophysiology of some diseases. Okay, the important point that you must know here in biosynthesis of adrenocorticosteroid, that the cholesterol responsible, or it is the building a block for biosynthesis of all the adrenocorticosteroid. It is responsible for biosynthesis of for aldosterone. It is responsible for biosynthesis of cortisol, and also it is responsible for biosynthesis of testosterone and estrogen. So if there is no cholesterol, mean there is no adrenocorticosteroid biosynthesis. So presence of cholesterol, so converted first thing into pregnenolone, and from the pregnenolone there are three biosynthetic pathways. Okay, so cholesterol first thing converted to pregnenolone, and then from pregnenolone, all other adrenocorticosteroids will biosynthesize. So the step of conversion cholesterol to pregnenolone called rate limiting step, and the enzyme that responsible or mediate this conversion, this process, called the rate limiting enzyme. Mean if this enzyme not available or blocked or non-functional, mean the process of cholesterol conversion to pregnenolone will not occur. And also the biosynthesis of mineralocorticoid, glucocorticoid, and androgen will not occur also. These these hormones, like for example mineralocorticoid, glucocorticoid, and adrenal androgen, there are systems to control its release, control its synthesis, and also inhibit its biosynthesis. In case of mineralocorticoid, it is regulated by the system called renin-angiotensin-aldosterone system. Activation of this system lead to increased production of aldosterone, so lead to increase the water and salt retention and increase the blood pressure. In case of glucocorticoid, there is something called HPA axis. So what we mean by HPA axis, mean H stand for hypothalamus, P for anterior pituitary, and A for adrenal cortex. Okay. When the cortisol level in the blood it is low, the hypothalamus, which is a specific area in the brain, responsible for synthesizing, responsible for releasing a hormone called corticotropin releasing hormone. The corticotropin releasing hormone lead to activate the anterior pituitary. It is another specific area in the brain. So pituitary gland, or the anterior pituitary gland, responsible for releasing the adrenocorticotropic hormone. So the adrenocorticotropic hormone by itself, it will activate the adrenal cortex, and the adrenal cortex will release the cortisol. So activation of hypothalamus lead to activate the anterior pituitary, lead to induce the adrenal cortex to release the cortisol. What about the negative feedback? There is inverse relationship or opposite relationship between level of cortisol and activation of hypothalamus. So as level of cortisol increased, lead to decreased activity of the hypothalamus. Okay, and this is what we say it is a negative feedback inhibition. I mean, when level of cortisol increase in the blood, lead to inhibit the hypothalamic activity. Inhibiting hypothalamic activity lead to inhibit the anterior pituitary gland activity, lead to inhibit activation of adrenal cortex, so no more cortisol will be synthesized and released, and vice versa. Circadian rhythm of cortisol, it is very important to understand the circadian rhythm. So what we mean by circadian rhythm of cortisol, it is give us information about when the cortisol or the glucocorticoid it is very high and when it will be low and lowest. So according to the references, the peak level of the cortisol will be in the morning. It is between the 6 and 8 a.m. So after 8 a.m., the cortisol level will decline until we reach to the midnight. At the midnight, it is the lowest level of cortisol will be. So what is the importance of this information, or when we will use this information, when we will can exploit this information clinically? There are diseases like, for example, Addison disease, which is example of adrenal insufficiency. Mean there is a low level or maybe no cortisol hormone released into the blood. So the endocrinologist, the strategy of endocrinologist, prescribing medicine, prescribing glucocorticoid, exogenous glucocorticoids, like for example, prednisolone, dexamethasone, betamethasone, any kind of glucocorticoid, any example of a glucocorticoid. Okay, so you must, in order to take benefit from this medicine, you must giving the drug, because this drug will mimic the structure of cortisol, And if you need to take a 100% benefit from this drug, you must also not only mimicking the structure of cortisol, you must mimic the function of cortisol, and when the cortisol it is at the highest level and when it is at the lowest level. So when you give exogenous glucocorticoid or glucocorticoid medicine, you must give the largest dose in the morning. Okay, so for example, if you give 100 milligram, for example, 50 milligram at least you must give in the morning, and the remaining of the dose must be divided afternoon and evening and so on. So the circadian rhythm of cortisol is very important, since it is give us information about when the cortisol it is very high and when the cortisol it is at the trough. So accordingly, we understand that the cortisol level it is very high at its maximum concentration in the morning, and at lowest concentration in the midnight. And prescribe, when we describe medicine for such patient, you must know that the highest level, the highest concentration of that drug, the highest dose of that drug must be given in the morning, not in the night. And the lowest concentration, the lowest dose will be in the night. Regarding the half-life, it is between 1 hour, 1 hour and a half. During the stress, it is increased. Okay, and even the medicine, exogenous medicine like dexamethasone, betamethasone, you write it to your patient, you prescribe it or describe it to your patient. You must tell your patient that in case of stress, in case of, for example, you have maybe surgery, even if there is a simple surgery, like for example, dental extraction, or maybe a serious surgery, like for example, open chest. Okay, the dose of this exogenous glucocorticoid must be increased accordingly. For example, if your patient take normally 25 milligram of betamethasone or dexamethasone, the dose in case of at the day of stress, at the day of the surgery, the dose must be increased, multiplied by 2 or maybe 3, or according to the doctor. We have important point that the metabolism of the cortisol occur in the liver, and it's entered the two phases of the hepatic metabolic pathway, the phase 1 and the phase 2. As we know, the phase 1 is conducted by cytochrome by hepatic enzyme like cytochrome P450, and after that the drug entered to the phase 2. In the phase 2, called conjugation phase, the drug or the cortisol will be conjugated with large compounds like glucuronide and sulfate. After that, the drug become water soluble and eliminated with urine. I need you to focus here on cytochrome P3A4. This enzyme, it is very important enzyme actually. It is responsible to metabolism, or responsible for the metabolic pathway or a large number of drugs. So this enzyme that responsible to cortisol, responsible also to metabolism of a large number of classes of medicines, drugs, exogenous drug, chemical agents. Okay, that we concluded from this information that the cortisol has a large number of drug-drug interaction, because we have too much drugs that act on this enzyme, on this hepatic enzyme. For example, any drug lead to increase level of this enzyme, so lead to increase the metabolism, lead to increase the clearance, and then decrease the blood concentration of the cortisol. Okay. On other hand, any drug lead to inhibit the cytochrome P3A4, lead to decrease the metabolism of cortisol, lead to decrease the clearance, excretion, and lead to increase the blood concentration of the drug or of the cortisol. So in both cases, the manipulation in the level of cortisol by increasing or decreasing, it will have its outcome. It may be lead to decrease the level of cortisol to subtherapeutic concentration, or maybe lead to increase the concentration of cortisol over than a therapeutic level. So either the drug become not efficacious, or maybe lead to drug to be responsible for the toxicological response. Before entering the hepatic system, the cortisol undergo the metabolism by another enzyme. This enzyme called 11 beta hydroxysteroid dehydrogenase. After that, it is metabolized by phase 1 and phase 2. This enzyme 11 beta hydroxysteroid dehydrogenase, there are two type 1 and type 2. The type 2 responsible for inactivation of cortisol. The type 1 responsible for activation to cortisol. So the type 2 responsible to convert the cortisol to cortisone, and the cortisone, it is activated again to cortisol by the type 1. These are the example of medicine that lead to increase and decrease the metabolic pathway of the glucocorticoids or cortisol. Phenytoin, phenobarbital, carbamazepine, these are anti-seizure medicine. Rifampicin or rifampin, antibiotic. Hyperthyroidism, it is a disease state. These are responsible to induce the hepatic enzyme, increase the clearance, and decrease the blood concentration of the drug. Decreasing the blood concentration of the drug may lead to decrease the concentration to subtherapeutic level. Enzymes that lead to inhibit cytochrome 3A4 lead to decrease the clearance and increase the level of the level of cortisol to a level that lead to a toxicological response, of course, with time, not directly. Drugs like ketoconazole, itraconazole, these are antifungal agents. Macrolide antibiotic, like for example clarithromycin, erythromycin, and antiviral like HIV protease inhibitor. All these lead to increased level of cortisol and may lead to toxicity. Regarding the mechanism of action of glucocorticoids is very simple and very easy to understand. Before going to mechanism of action, let's remember we have two kind of receptors. We have the internal receptor and the surface receptor. What I mean by surface receptor, these receptors that present on the outer side of the cell of the membrane. Okay, so most of the drug bind to this, but some drug, its receptor, or some drugs, their receptors are located internally within the cytoplasm. So in order to going or to have ability to penetrate the biological membrane, it must be a lipophilic. So the lipophilic medicine are passively will penetrate the biological membrane and reach to the cytoplasmic area. In the cytoplasmic area, there are receptors. For example, in case of cortisol, or glucocorticoid, the receptor located in the cytoplasm, and it is called the cytoplasmic glucocorticoid receptor or GR. Okay. GR without binding to the glucocorticoid, it is inactive and it is bind to a kind of protein called heat shock proteins. These heat shock protein are very important for integrity of these receptors, integrity of these proteins. So prevent the dysregulation. So protect this receptor to be full functional or normally functional. Okay. So when the glucocorticoid bind to its receptor in the cytoplasm, this receptor activated. This heat shock protein will dissociate, and the complex of the growth hormone, glucocorticoid, and the receptor and its receptor will move toward the nucleus, and the nucleus will bind to the DNA. In the DNA, there is a specific area called a glucocorticoid response element. This glucocorticoid response element, it is a specific site that responsible for binding of what? For binding of the complex of the glucocorticoid and the receptor. Once this binding, once this interaction occur between the complex and the glucocorticoid response element, there will be a variety of action. Okay, for example, we have transactivation and transrepression. So what we mean by transactivation and transrepression? Transactivation mean increase a transcription, mean increase a production of certain kind of protein. Transrepression mean inhibit biosynthesis or synthesis or certain products, like for example certain proteins. Okay. In case of transactivation, lead to increase the production of anti-inflammatory proteins, like for example annexin A1, which is responsible for inhibit production, releasing, synthesizing the phospholipase A2. So the question is, what is phospholipase A2? If you know it, so you are perfect. If you not know it, it is okay and normal, because we will study it, we will take it, we will dive deeply about the phospholipase A2 in the lecture of non-steroidal anti-inflammatory drug. But one point, there is direct relationship between, or direct proportion between the phospholipase A2 and the inflammation. Increase phospholipase A2, increase inflammation. Transactivation lead to inhibit formation of phospholipase A2 by increased production of lipocortin 1. Also lead to increased transcription of anti-inflammatory cytokines like interleukin 10. Transrepression lead to inhibit the action of some pro-inflammatory mediators, pro-inflammatory factors, like for example nuclear factor kappa B, and also activator protein 1. When we inhibit the level of these pro-inflammatory factors, lead to decreased production of interleukin, different types, subtypes, and subtypes of interleukin, like for interleukin 1, 2, and 6, tumor necrosis factor alpha, and cyclooxygenase 2. By inhibit these pro-inflammatory factors, lead to decrease in inflammation. So we have we have more than one mechanism of anti-inflammation. Okay, and this is why, or this is the reason why these glucocorticoid, they have a strong or potent anti-inflammatory action, because we have more than one mechanism. We have two or maybe more mechanisms for its anti-inflammatory activity. So simply, a simple memory trick. If we need to memorize the mechanism of glucocorticoid or adrenocorticosteroids easily, uh, remember these three words: bind, move, and modify the gene. Bind to the internal cytoplasmic receptor, move to the nucleus, modify the gene, modify the DNA, and lead to transcription and or lead to transactivation and trans repression. Okay, we have number of outcomes, number of results, number of actions, or maybe it is physiologic action, and when it is become over than the normal, become pathological action. Okay, cortisol normally responsible to increase the production of glucose in the liver. This is a process called gluconeogenesis. So increase gluconeogenesis mean lead to increase the hepatic production of glucose, increasing the hepatic production of a glucose, and then it is released to the blood. This lead to hyperglycemia. But the hyperglycemia or elevating in blood level of glucose not occur only by increasing in production of glucose in the liver and releasing it into the blood, but also by its anti-insulin action. What we mean by anti-insulin action, the insulin responsible to peripheral uptake of the glucose and decrease the blood level of glucose. But the glucose or the glucocorticoid responsible to inhibit the insulin action, lead to inhibit the peripheral uptake, the tissue, the cells, the skeletal muscles uptakes of what? Of glucose. So this lead to elevate level of glucose in the blood and lead to hyperglycemia. This is why it is contraindicated or maybe given with caution in diabetic patients. Okay, this is the process of gluconeogenesis. Also, it is responsible to increase the protein breakdown. So, increase the protein breakdown mean lead to increase the proteolytic activity, lead to increase the proteolysis. Okay, what we mean by proteolytic activity and what we mean by protein, what is the outcome or the result from the protein breakdown? The result it is amino acid, and this amino acid recycled again and uptaken by the liver for a process of gluconeogenesis. So increase the production of protein breakdown, it is support the gluconeogenesis in the liver with amino acid, with alanine amino acid, for example, in order to exploit it in the process of gluconeogenesis. Increasing in the protein breakdown with time lead to muscle wasting. That individual appear very weak, appear fatigue all the time, cannot tolerate the heavy loads, for example, cannot pick up heavy loads. So this is because of the decrease in the size of the muscle. Okay, we have a process called lipolysis. The cortisol it lead to lipolysis. Normally, the lipolysis occur because it is very important. Before process of going to process of lipo, whether it is normal or abnormal, the lipolysis it is mean convert the triglyceride to free fatty acid and glycerol. Okay, triglyceride conversion to free fatty acid and glycerol. Okay, this is very important because it is in the normal case this free fatty acid it is exploited as energy for our body in order our organs, our tissues, our cell except their normal physiology, their normal function. We need free fatty acid, we need normal level of energy, but with time using of the exogenous glucocorticoids for long period of time repeatedly or increasing in the endogenous cortisol abnormally lead to shift from normal lipolysis to abnormal lipolysis. Abnormal lipolysis lead to fat redistribution. Fat redistribution. So first thing, the energy will be exploited in many physiological function. Okay, but with time and with prolonged use of cortisol, exogenous glucocorticoid, or abnormal elevate in level of cortisol, lead to fat redistribution. What we mean by fat redistribution? Look to this here. Okay, the fat distributed in some specific area in the body. For example, in the face, lead to something called a moon face. In the neck, lead to buffalo hump. Okay, in the trunk, lead to big tummy, and also as a result of breakdown of the muscle and proteolysis, the limbs become very thin. Okay. Process of lipolysis mediated by action of enzyme called hormone sensitive lipase. So the hormone sensitive lipase responsible for breakdown of free fatty acid of triglyceride to free fatty acid and to glycerol. Okay, so the process of lipolysis support the liver, the gluconeogenesis process in the liver with glycerol. So this glycerol result from the lipolysis pathway, and this amino acid alanine, it is uptaken from this pathway, increasing the protein pathway. So gluconeogenesis need glycerol, need amino acid. Glycerol uptaken from the triglyceride hydrolysis, lipolysis, and also the protein or amino acid obtained from the proteolytic activity of cortisol and breakdown of proteins to amino acids. Okay. Cortisol using of exogenous glucocorticoids, or when the cortisol level it is so high, abnormally high, lead to osteoporosis. So what we mean by osteoporosis? Mean the osteoblast function decrease and lead to osteoclast activity. And we will take this lecture too in the future, inshallah. So when we say osteoclast activity increase, mean the demineralization increase. When the osteoblast function decrease, mean the mineralization decrease. So the osteoporosis lead to demineralization and lead to weaken the bone structure and lead to osteoporosis. Okay. Growth retardation, this is why it is contraindicated in the children. This is because the cortisol, the glucocorticoid, responsible for inhibition of insulin-like growth factor. Insulin-like growth factor responsible to mediate the action of growth hormone. So the growth hormone cannot do action without the insulin-like growth factor. Inhibition of the insulin like growth factor, the growth hormone will be inert, so lead to retarding the growth, stopping the growth, abnormal growth. Fetal lung maturation, this is very important, and the gynecologist or gynecologist and obstetrician using the glucocorticoid, the exogenous glucocorticoids, to ensure that the fetal lung mature. And the dose of glucocorticoid, for example, dexamethasone or betamethasone, these are long acting and stronger than the other glucocorticoid. Before 48 hours, using one dose, for example, 10 milligram or 12 milligram. After 18 to 24 hour, from the first dose, the dose repeated again. So 48 hour before the woman giving birth, taking one dose, and after 18 to 24 hour from the first dose, another dose. The woman or the that pregnant woman will receive another dose. This is important because it's this glucocorticoid responsible to increase the surfactant protein synthesis. The surfactant protein synthesis, it is important because it is inhibit the lung collapse. Mean when the woman giving birth, the baby will be intact, will be out of the respiratory distress. Cases of respiratory distress, actually it is very it is obvious, it is high, and such cases respiratory distress can be prevented by giving doses of glucocorticoid to such pregnant. Cortisol, increased level of cortisol or using exogenous glucocorticoid repeatedly for long period of time lead to inhibit the collagen synthesis. And we all know that the collagen, it is very important for the firmness of the skin. So no collagen, the skin become brittle, become easily damaged, and lead to bruising, for example, and thinning of the skin. Cortisol on the CNS has acute effect and chronic effect. In case of acute effect, lead to insomnia, lead to anxiety, and may lead to increased appetite. Chronically, lead to depression. Okay, so the chronic use of steroids, of adrenocorticosteroids, lead to depression and increase intracranial pressure. Okay, lead to increase the RBC and platelet level and neutrophil, and decrease the immunological cells, like for example lymphocytes, T lymphocytes and B lymphocytes. Effect on renal and GIT. So just look, there is decline in the water excretion. So increasing the weight occur as a result of increasing appetite, and also decrease the water excretion, mean retention of the water inside the body. So this lead to increase the weight. Increase risk of peptic ulcer or GIT ulcer. Why? Because of these 2 points: decrease or increase the gastric acid and pepsin secretion, increase the gastric acid, the hydrochloric acid, and pepsin secretion, and decrease the lining or the layer that lining the stomach, the internal or the layer that lining the luminal side of the stomach. So increasing production of hydrochloric acid and decrease of the protective layer lead to increased risk of the ulcer. These are, of course, the information present in the table. It is just for clarification, but the important point, it is the types and classifications of the glucocorticoid or adrenocorticosteroid. We can classify the glucocorticoid according to the duration of action into short, intermediate, and long. The short, like for example, hydrocortisone, just focus on the names: hydrocortisone, cortisone, prednisone, and prednisolone, methylprednisolone. Okay, all these products are available in our market, but also there is a meprednisone. Meprednisone, this is not available in our market. Okay, intermediate acting glucocorticoid like triamcinolone. Okay, and it is available in our market. Long acting like dexamethasone and betamethasone. And we have also mineralocorticoid like fludrocortisone, which is present in our market. There is another mineralocorticoid like desoxycorticosterone acetate. Okay, so the glucocorticoid can be divided, classified according to duration of action: short, intermediate, and long acting. Memorizing these products, these drugs, it is very essential. The other information here in this table, it is for clarification. Discussion. Okay, a pregnant patient requires glucocorticoid therapy for certain disease, for example, adrenal insufficiency, Addison disease. Would you prescribe prednisone or prednisolone? Explain your choice based. Okay, explain your choice based on placental enzyme activity. Okay, as a discussion, the prednisone and prednisolone, cortisone and cortisol. So, what are the differences between these two forms? If you know the prednisone, it's the same as a prednisolone, same product and same mechanism of action. But the point that the prednisone different from the prednisolone in that it is a prodrug. Prednisolone, it is not prodrug. It is already active drug. So what we mean by prodrug? Mean it is inactive drug, but need to hepatic enzyme in order to be activated. So as a pharmacist, which one you think it's preferable form of glucocorticoid? Prednisone glucocorticoid or prednisolone? In my opinion, and according to the references, prednisone it is the preferable form during the pregnancy. Why? Because as I told you, the prednisone it is a prodrug need to hepatic enzyme to be activated, so it is activated within the maternal circulation, within the mother circulation, while it is not activated in the fetal circulation, because this enzyme not active in the fetus liver, fetal liver. Okay, so when this prednisone it is converted to prednisolone, so the prednisolone by itself cannot reach to the fetal circulation. Okay, why? Because of 11 beta hydroxysteroid dehydrogenase type 2. Okay, this type 2 responsible for deactivation of the prednisolone again and convert it back to the prednisone. Okay, so we have two mechanisms to protect the fetus from action of glucocorticoid. First thing, we give the mother prodrug, and this drug will be activated only in the in the maternal circulation, and not in the fetal circulation, and also in the placenta. Responsible, there is enzyme called 11 beta hydroxy steroid dehydrogenase type 2, which is responsible to activation of prednisolone into prednisone again, or into its inactive form prednisone. So what about the therapeutic uses of cortisol? It is used in case of lip replacement therapies, like I said before about Addison disease. It is used in the congenital adrenal hyperplasia. So what we mean by congenital, from the name congenital, mean inherited adrenal hyperplasia. The defect in case of congenital adrenal hyperplasia may be due to, of course, the defect in the enzyme. So either there is defect, it is non-functional, or there is deficiency. Okay, this is the biosynthetic pathway as we uh, clarified it in the previous slides. So maybe the defect in the 21 beta hydroxylase, so congenital adrenal hyperplasia. It may be due to deficiency in number of enzymes. If the deficiency occur in the enzyme called 21 beta hydroxylase, so look to the biosynthesis pathway and search for 21 beta hydroxylase. You will see it is located here. Okay, so this enzyme responsible or catalyze the metabolism of or the process of conversion the progesterone to deoxycorticosterone, responsible for a conversion of hydroxyprogesterone to deoxycortisol. Okay, so if you inhibit this enzyme, lead to inhibit the process of conversion of progesterone, for example, to deoxycorticosterone, lead to accumulation of progesterone, lead to accumulation of what? Hydroxyprogesterone. Okay, accumulation of progesterone and hydroxyprogesterone lead to change the metabolic pathway from biosynthesizing the glucocorticoids and mineralocorticoid into synthesis of adrenal androgen, testosterone and estradiol after testosterone. So this conversion in the metabolic pathway of in the biosynthetic pathway from synthesizing mineralocorticoid and glucocorticoid into adrenal androgen hormones biosynthesis lead to something called virilization. So what we mean by virilization? Mean, look here, development of male secondary sexual characteristic in female. Mean the female show expose some secondary male characteristic, like for example hoarseness of the sound of the voice, increase the hair in the face, for example. So these are male secondary sexual or characteristic, not only the sexual characteristic. Just look here again. So if the defect or deficiency in the beta 21 beta hydroxylase, which is responsible for virilization and decrease in glucocorticoid and mineralocorticoid, okay, level. If the defect in the 11 hydroxylation, mean there is a defect in enzyme called 11 beta hydroxylase. Okay, the 11 hydroxylation a process mediated by enzyme called 11 beta hydroxylase. 11 beta hydroxylase responsible for conversion of deoxycorticosterone to corticosterone, responsible for conversion of deoxycortisol to cortisol. So when we block the conversion of deoxycorticosterone to aldosterone to corticosterone then to aldosterone, lead to accumulation of deoxycorticosterone. Of course, the deoxycorticosterone characterized by mineralocorticoid activity. So this lead to increased retention of water and salt and lead to hypertension. But the effect it is weaker than the aldosterone. So accumulation of deoxycorticosterone, if it is a normal level, so lead to not obvious mineralocorticoid activity. But accumulation in high level lead to mineralo or strong mineralocorticoid activity. When the deficiency or the defect in the 17 hydroxylation process, okay, 17 hydroxylation a process mediated by enzyme called 17 alpha hydroxylase, okay, and 17 alpha hydroxylase located here, it is responsible for conversion of pregnenolone to alpha hydroxypregnenolone. Okay, so when you inhibit this biosynthetic pathway, lead to inhibit or decrease the biosynthesis of adrenal androgen hormones. Okay, so lead to hypogonadism. Also, it is used for Cushing syndrome, especially after the adrenal removal. We know when there is adrenal removal, there is decline, not just decline, there is completely decline or decrease or decrease in level of glucocorticoid. So in order to inhibit such crisis, inhibit such glucocorticoid low risk, we give the patient what glucocorticoid. And as I said, when you give glucocorticoid, you must mimic the normal circadian rhythm. So the highest dose in the morning, the lowest dose after that. In case of aldosteronism, we have high level of aldosteronism. So we give such patient, such individual, a glucocorticoid. Why? In order to induce the negative feedback inhibition. So, in giving glucocorticoid lead to inhibit the adrenocorticotropic hormone effect on adrenal gland and inhibit release, further release of aldosterone. Glucocorticoid can be used also in diagnostic purpose, for example, diagnosing of Cushing syndrome, and this test, the test for diagnosing Cushing syndrome called dexamethasone suppression test. Using the glucocorticoid for inflammatory situations, like for example respiratory diseases, asthma, COPD, allergic rhinitis. These are inflammatory situations uses. Okay. We know that in case of asthmatis and inflammatory chronic inflammatory disease, the glucocorticoid is used as a treatment, not as for acute situation. For acute situation, another medicine we have, like for example beta 2 agonist like salbutamol. Eczema and psoriasis, these are another inflammatory situations. Psoriasis is autoimmune disease. We have rheumatoid arthritis, gout, and osteoarthritis. All these topics we will take it in next lectures. But just simple information about these diseases. Rheumatoid arthritis, it is autoimmune disease that the immune system attack the joints, so lead to inflammation. Gout, it is accumulation of uric acid or sodium urate. Accumulation of this uric acid or salt of uric acid lead to inflammation. Osteoarthritis is also an inflammatory situation. We use glucocorticoid for such situations, and it is very effective, very potent, and very efficacious for these cases. Again, for autoimmune disease, like we have also multiple sclerosis and systemic lupus erythematosus. For organ transplantation, to inhibit the allograft rejection, we have, for example, autoimmune hemolytic anemia. In case of oncology, we have leukemia and lymphoma. We must give the patient glucocorticoid because such cancer need glucocorticoids, steroids as a strategy for its treatment. Allergic conditions, like for example anaphylaxis, using of H1 blocker antihistamine, it cannot reverse the anaphylaxis efficiently. This is why we can use glucocorticoids either alone or in combination with antihistamine. So it will efficiently reverse the action of anaphylaxis. It is use of inflammatory GI disease, like for example, ulcerative colitis and Crohn's disease. About the side effect also, of course, the side effects if you look to the list of the side effect, all the side effect we were talked about it in the previous slide. For example, one of the adverse effect, hyperglycemia. So hyperglycemia caused due to increase in gluconeogenesis, fat redistribution. In the beginning, the lipolysis lead to uh, support the body with energy, but with continuously using of glucocorticoids for long term lead to redistribution of the fat in the face, in the central obesity, or in the neck, buffalo hump. Proteolysis also lead to muscle wasting and weaknesses. Osteoporosis, growth suppression, all these we talked about them in the previous slides. Increased risk of infection, and this is because it has immunosuppressive action. We have a neuropsychiatric effect, the effect on the CNS. It is either acute or chronic. The acute effect, mood change, insomnia, and anxiety. Chronic use lead to depression. Hypertension and fluid retention, it is among the side effects. Acne and inhibit the collagen synthesis, lead to lead to lose the integrity of the skin, and the skin become thin, brittle, and easily damaged. Ocular effect like glaucoma, cataract, increased risk of ulcer, and this is because of increased production of hydrochloric acid and decreased production of the internal, or the layer that lining the mucus layer that lining the luminal side of the stomach. Also, it's very important to know that the glucocorticoids, it is they are responsible for delayed the wound healing, for menstrual irregularities, and also for something called a vascular necrosis. So necrosis that hit the femoral head. Now we have number of medicines, number of drugs that act or counteract the action of different kinds of adrenocorticosteroids, like for example, drugs that antagonize the action of adrenal androgen, the drugs that antagonize the action of glucocorticoid, and also drugs that antagonize the action of mineralocorticoid. For example, we have amino glutathamide responsible for inhibit this step. So what is the name of this step? Who know? It is the rate limiting step. It is the essential step that is responsible for biosynthesis of all adrenocorticosteroids, the aldosterone, the cortisol, the testosterone. The ketoconazole, responsible for inhibiting of multiple enzymes, inhibit the cytochrome P11A1, which is responsible or it is the rate limiting enzyme, so inhibit the conversion of cholesterol to pregnenolone, so inhibit the aldosterone, cortisol, and testosterone biosynthesis, but also inhibit another enzymes, like for example cytochrome P17, and also responsible for inhibit of cytochrome P11B1. So inhibit formation of cortisol by two mechanism, by inhibit cytochrome P11B1 and also by inhibit the cytochrome P11A1. So essential enzyme, it is this which is responsible to inhibit the rate limiting step and lead to inhibit the biosynthesis of all adrenocorticosteroids. We have metyrapone responsible for inhibition of 11 beta hydroxylase, or it's named cytochrome P11B1, responsible for inhibit the conversion of deoxycortisol to cortisol. The difference between metyrapone and another member of this class, it is the only one safe for pregnancy. Abiraterone, it is responsible for inhibition of cytochrome P17. We have mitotane. Mitotane, it is used in case of adrenocortical carcinoma. So in case of adrenocortical carcinoma, we need to we get rid of the adrenal cortex or adrenal gland entirely. So we use the mitotane. This lead to activate the cytotoxic T lymphocyte, which is attack and destroy the adrenal gland entirely. Okay. Glucocorticoid receptor antagonists, like for example mifepristone. Mifepristone, it competes the cortisol, compete the glucocorticoids for its binding site at the cytoplasmic receptor. So inhibit binding of glucocorticoid to its cytoplasmic receptor and inhibit the porting of the complex to the nucleus, and then lead to inhibit that binding to the DNA, inhibit the transactivation and transrepression. We have anti-mineralocorticoid activity, like for example spironolactone, eplerenone, and also we have drospirenone. Spironolactone and eplerenone, these are competitive aldosterone receptor antagonists. Mean the aldosterone receptor antagonist mean blocking the cytoplasmic receptor, inhibit aldosterone bind to its receptor, to its internal receptor. In addition to this, it has anti-androgenic activity. This anti-androgenic activity with time lead to something called gynecomastia. It is enlargement in the breast in the male and lead to menstrual irregularities in the females. Eplerenone has same mechanism of spironolactone action, but with no anti-androgenic activity, mean lead to no gynecomastia and menstrual irregularity. Drospirenone, it is another anti-mineralocorticoid activity, but it is present in the combination of oral contraceptives. Last medicine, trilostane. Trilostane, it has activity or efficacy just similar to aminoglutathione. Okay, why? Because it is responsible to inhibit conversion of cholesterol to pregnenolone, so lead to inhibit the rate limiting step in biosynthesis of adrenocorticosteroids, so inhibit the biosynthesis of all glucocorticoids, adrenocorticosteroids, aldosterone, cortisol, and testosterone. And thank you for your attention.